Thank you, operator. Thank you to everyone on the line for joining us for today's COVID-19 daily media call for Tuesday, April 21st. Governor Walz is not able to join us for today's call, but our speaker lineup will include Minnesota Commissioner of Health Jan Malcolm, followed by Infectious Disease Division Director Chris Erzman. We also have Health Regulation Division Director Michelle Larson on the line to provide more details about how the state works with long-term care facilities to prevent COVID-19 infections and to deal with cases when they do happen. Following the opening comments from Commissioner Malcolm and Directors Erzman and Larson, we will open it up for questions from reporters. With that, I will turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Just to start, as usual, with the quick situation update globally and nationally first. As of early this morning, the global total of cases was nearly 2.5 million and 171,000 deaths. In the United States, we were rapidly approaching 788,000 cases and 42,364 deaths. In Minnesota, we are at a new lab-confirmed total of 2,567 cases, an increase of 97 from yesterday. So these last number of days, we've been on kind of a similar pace of daily increases. We had also 18 deaths reported since yesterday, but we also learned that one of the deaths had been reported in error. So our net increase was actually 17, bringing us to a new total of 160 deaths in Minnesota, which we are every day sorry to learn and think about the loss of those loved ones. This new set of 18 deaths includes 16 in Hennepin County, one each in Ramsey and Washington. Again, 14 of these 18 deaths occurred in residents of long-term care facilities, which is, again, part of the reason that we're going to give some additional focus to that topic today. The total includes 3 people in their 90s, 9 people in their 80s, 2 in their 70s, and 4 in their 60s. As of today, 1,254 patients have been released from isolation. There are currently 237 patients hospitalized, 117 of those in intensive care. There was no net increase in hospitalizations yesterday, so it appears that for the most part there were folks moving from intensive care into regular medical surgical beds. I think with that, perhaps I'll just remind that we do have a large number of long-term care facilities in the state with at least one case, whether that is a healthcare worker or a resident. And as Chris, I'm sure, will detail, we've been closely tracking the situations in these facilities and surrounding a facility with even one case with some additional attention and resources. So I think at this point, pass it off to Chris Erzman, and then Chris will pass it to Michelle Larson. Thank you.
Thank you, Commissioner. As you're aware, and as we've talked about on prior briefings, we know that residents of congregate care settings, or those in assisted living, nursing homes, group homes, are at very high risk of severe disease due to COVID-19 because of their older age and medical conditions. And so because of that, when we're made aware of the potential for COVID-19 to be introduced into one of these settings, we take very rapid action. But even before we had cases identified in congregate care settings, we had been proactively working with leadership in these facilities. So since March 4th of this year, we have been having weekly calls with long-term care facilities and provider organizations to relay up-to-date information about recommendations, what's going on with the outbreak, any changes in guidance from the Department of Health or CDC, including guidance from our Health Regulation Division. And so we have a call today, this afternoon, and I can tell you that our most recent call was attended by almost 1,500 participants. So these are sought-out calls. when we're notified about a confirmed case of COVID-19 in a congregate care setting, we initiate a comprehensive investigation. We start by having a call with administrators and clinical staff of the facility, as well as representatives from the Department of Health, from our surveillance, infection prevention, healthcare worker exposure work groups, et cetera. And so initially, our goal is to do an extensive case interview to learn more about the case and who their contacts may have been, so that we can identify potentially exposed residents, staff, and healthcare personnel. And we have developed guidelines for these resident healthcare personnel and staff contact tracing, as well as guidelines for assessing the type of exposure that someone may have had, all based on guidance from CDC. And based on these investigations and interviews, we will make recommendations for isolation, quarantine, and or work exclusion. So this is all part of the initial assessment. One of the other things that we do with the facility is we go over infection prevention and outbreak control measures. And this includes things like isolating ill residents, or if it's not possible to isolate a resident in a private room, to make sure that we are cohorting ill residents together. We also make recommendations for quarantine of exposed residents, so that residents who may have been exposed to a case are also kept separate for 14 days in case they would develop symptoms. We go over the type of precautions that the facility should use when caring for these patients, these residents, universal precautions, droplet precautions, and we also talk about the type of personal protective equipment that should be worn when caring for ill residents. We recommend universal masking for source control, and you've heard us talk about this even in the non-healthcare setting, that we all can wear masks when we're out and about as a means of source control. That is, limiting the opportunity for the wearer to share droplets with the people around them. So we do recommend that also in the long-term care setting. We make sure that visitor restrictions are in place and that group activities have been canceled. And this has taken place in just about all facilities, but we have, we check on this because we have identified some, that may have missed that recommendation. And then we also provide guidance on disinfection and cleaning. And it's a lot of information to convey, and so we have a team of infection preventionists or infection control specialists who are available and can do a virtual assessment of the facility and walk through the facility with them and work with them on specific steps that they can take to make their facility as safe as possible. We also provide tools on monitoring of healthcare workers, making sure that they're assessing both their healthcare workers as well as their residents for potential symptoms of COVID-19. An important part of what the facility does in terms of having a first case of COVID is making sure that they're communicating with residents, their families, and staff, and so we provide them with a letter and talking points that can be used. And we want to be sure that facilities have the type of close and ongoing support that they need. So each facility that has an outbreak is assigned to a nurse case manager, and the nurse case manager works with them daily in identifying ongoing issues. If they have questions or concerns about infection control, personal protective equipment, staffing issues, any of those things, the case manager is the link back to the multiple teams that we have, the healthcare worker team, the infection control team, the EPI team, as well as they serve as a link to our State Emergency Operations Center, which Michelle is going to be talking about. So they end up being the boots on the ground for the facility so that they have a single point of contact within the agency and can be easily connected to whatever resources that they need. more recently, we are helping facilities, in addition to dealing with a case in a resident, staff member, a contracted staffer, we're also helping facilities address the safe transfer of patients with COVID-19 to their facility. So there are situations in which an acute care setting needs to transfer someone who has had COVID-19 into a long-term care situation, or there's been a need to transfer between facilities. And so we have some facilities where there has not been a case, but they have the space and the staffing and PPE that's needed to be able to accept a resident. And so our nurse case managers are also assigned to these facilities to help them navigate that transfer. The goal is to ensure that these facilities have the tools and resources that they need so that they can safely care for these new residents. That gives you an overview of the kinds of things that we're doing on the outbreak response side. But what we found is that we need more resources and we need to do more forward thinking. And so I'll turn it over to Director Michelle Larson to talk to you more about that type of work.
Hi, everyone. Thanks, Chris. This is Michelle Larson. I'm the Health Regulation Director at the department. And going off of what Chris said, we really look at it once we get past this point of that initial response as a two-pronged planning approach. So there's this current response that Chris just talked through, and I'll extend off of that. And then we have more of a long-term planning that we're trying to do as well. So the Minnesota Department of Health is also part of the State Emergency Operations Center. And I'm the lead for the long-term care work within the SCOC, which is the acronym for that I'll continue to use. So as the case manager and the EPI team continue to be the conduit back and forth to the facility, they will reach out if something is starting to brew. If it's getting to be a bigger issue than maybe what the facility can handle. And that can happen pretty quickly. They are often working with local resources or maybe the emergency manager or local public health. But if things start getting worse, for an example, if there's a major staffing problem at the facility where staff are becoming ill, they might call out and ask, what can we do for staffing for this particular facility in this particular area? So the SCOC may be called to help plug in the right connections to help them with their particular resources. The SCOC role is not there to fix everything for the facility along the way for every part, but to be a conduit back to resources that could possibly help. A lot of the times, obviously, state or local government agencies may be able to help with this, depending on what it is. Currently, in order to help with immediate response, where we see a facility really starting to be overwhelmed, the SCOC is building out a crisis team model. So we're starting to do that now, like where Chris said that they're calling back in for help, and we're building out a more formal model of this, made up of local and state staff. So once we get that notification by a case manager and that EPI team, a crisis response team could be out there for only about 3 or 4 days, just to be on site to help the facility administrator and local partners identify areas that could assist. It's important to understand that there's a lot of different types of long-term care facilities around the state, and and depending on what their outbreak is at that time, they may be having different needs. So not one size fits all for this scenario. So to really get a team out there and help them immediately is helpful to them. Another immediate help for long-term care facilities that we are putting together in SCOC is an information line just for long-term care. That's different than the MDH hotline provider line. This is a type of phone line that's tied to 911 and 411 for these long-term care facilities so that they can get help with a specific need if they just have a question or they can't get a hold of somebody that they need to get a hold of, because we really want to round out as much response for them that we can at all hours of the day, all the time. So that's those immediate current response work that's going on. For long-term planning, as this continues to go on and we think about how we're going to sustain this from the state resource side and continuing to help our local partners. It's our goal to get in front of these vulnerable facilities proactively so that we have a better idea of who can help, where, with fast-moving outbreaks in long-term care facilities. We are continually refining our processes and communications and every aspect of every work that we do to help these facilities and to better understand what the needs are of these facilities and what is available in their communities. For instance, we have a part of the department that regulates these long-term care facilities. So we really want to go back in and look at where are facilities that just have infection control problems on a non-COVID day. What facilities haven't been surveyed in a long time, and really go back and proactively contact them and get out there and try to help them before they have an issue that gets out of hand and they really have a crisis overnight. Mike, that's about it. I can turn it back over to you if there's questions.
Great, thank you. Operator, I think we're ready to take questions.
At this time, as a reminder to ask a question, please press star followed by the number 1 on your telephone keypad. Your first question comes from a line of Aaron Hassanzadeh with WCCO. Your line is open.
Hi, thanks for taking my question. Since today is focused on long-term care facilities, we just want to elaborate on families that may have been thinking about putting a loved one into a care facility and are perhaps holding off on that. If this does go on for months on end or until we get a vaccine, what is the recommendation for families who may have a loved one who should be in that setting, but they're kind of hesitating to put them there? What's the recommendation for families like that?
Well, this is Chris Erzman. I'll start, and I think Michelle can probably add to this, but we've gotten that question both for families that have concerns because COVID has been identified in the setting where their loved one is, and certainly we've heard of situations in which families have chosen not to place a loved one in a facility. And our recommendation is that obviously it's a decision that the family has to make, but it's important that they make sure that their family member has access to all the needed services and cares that they require. And oftentimes, long-term care facility is the best way for that to be provided. But I'll let Michelle comment as well.
Thanks, Chris. And again, going a lot on what Chris said, it depends on the facility, what capacity they have as well. We certainly don't want families to feel, if they have a loved one that's in a condition that they're unable to take care of at home, we would certainly want to encourage them to find help for that. But we can't have facilities not accept new clients. So I think it just really depends on the case by case in the facility.
I'll follow up then and saying if they feel like they can take care of them at home, is the recommendation to do so for the foreseeable future?
I think that's definitely a family decision, but if they feel that they can provide the care, then it's much more about how they feel about continuing to do that as opposed to weighing the care needs of the family member against their concerns about COVID.
Your next question comes from the line of Brian Arola with Minnesota Free Trust. Your line is open. Brian Arola, your line is open. Your next question comes from the line of Jeremy Olson with the Star Tribune. Your line is open.
Hi, I guess I had a question that jumps back a little bit from the long-term care lens specifically. It's wanted to ask more of a progress report question, maybe for the commissioner on where we are at, because the messages can be mixed to people right now. I mean, there's no exponential growth in cases, but then we had 17 deaths today. We hear about chance of testing as many 5,000 per day, and now our daily testing numbers are actually down. we open businesses, then JBS shuts down. You get the point. There's progress, and then there's, we seem to go 2 steps forward and 1 step back, and it creates some confusion in the public. So I just love your assessment on where we are at in meeting our goals and dealing with this right now.
Thanks, Jeremy. This is Commissioner Malcolm. That's a very fair and very good question, and I think you're absolutely right. This is not a simple situation where everything is going to be necessarily going all in the same direction at the same time. I think we are going to have to learn how to manage this and how to live with this in different stages, in different ways, at different times. And I think you're going to hear more in the coming days about kind of the framework in which we need to think about the stages of this and what might make sense when. I get the point that it seems contradictory to say this is a stable situation, although it's clearly continuing to grow. Every day we see more cases, and sadly every day more deaths. I think, and I'll invite Chris to comment too, from the standpoint of it's not that the epidemic isn't growing, it's that it's growing so far in a measured way that is not exceeding our capacity to respond, either to respond with very quick and thorough case investigations that help us to continue that work of identifying cases, identifying the contacts of cases, and still working to try to help contain the spread of the epidemic by the classic public health measures of case investigation, isolation, and quarantine. So when we say it's a somewhat stable situation, it means we're able to do the things that we have the ability to do to kind of keep it in check, so to speak. And certainly the healthcare capacity question that we keep talking about, we're closely monitoring the rate of growth in the cases versus our ability to keep pace with that on the healthcare side. And clearly that is still in quite good shape in terms of the capacity to deal with the needed hospitalizations. The issues around certain environments that would be vulnerable to more rapid spread, and I think Chris made this point yesterday in the briefing, the same kind of phenomenon and dynamics that we've seen in any congregate setting, any setting of close quarters, whether that be a long-term care facility, a homeless shelter, an incarcerated population, or some kind of large, highly concentrated workplace settings, needs special attention. And I think part of our challenge is to get better and better at rapid response, as Chris was saying, to really kind of have the systems lined up in advance, because we know this is going to continue to happen, that we'll have hotspots in a local community or hotspots in a particular setting that we'll want to really surround quickly with as thorough a response as we can. So we still feel that while we're always can get better and working to get better, that we're making good progress on growing our capacity to meet the needs of the epidemic as it continues to grow as well. We talk about things like the doubling rate of the cases, and that's been kind of remarkably stable. Yes, it's growing, but it's kind of growing on a pace that we think we can manage. But I would invite Chris to say more about your perspective, Chris, on this.
Yes, sure. Thanks. I think what I'd like to emphasize that the commissioner said is that while it may seem that we're in a lull right now and everyone's waiting what's going to happen with the shelter in place, and we know more. We're going to see more cases. We absolutely know we're going to see more cases. But what this time frame has allowed for is that while we're seeing a lot of cases, as we said, in these congregate settings, it's allowing us to deal with these situations. So we're dealing with long-term care. We're making sure, as Michelle indicated, that we're standing up resources in the State Emergency Operations Center. Certainly, we have been preparing for the potential for a pandemic for a long time, but even as we implement the things we thought we would need to do, we're learning about more things that we can do to make our response better. And so in this interim time, we have had the opportunity to work on these long-term care situations and stand up additional resources that we can use to respond going forward. Even with this situation with JBS, it's an opportunity. We're responding there, but it's also an opportunity to take lessons learned and apply those across the state in other facilities very much like that, so that we're learning and growing even as we're implementing the plans that we had in place at the beginning of this pandemic. We're enhancing them. And so this time frame where it seems like it's potentially stable, we know there are going to be more cases, it's allowing us to address some of these congregate settings in a more meaningful way, so that as we move forward with opening up society more, that we're in a much better place to deal with and address the additional cases that we know that we will see.
Quick follow-up then on one of those kind of oddities in the numbers, though, is, we had a lot of confidence and talk about increased testing, but the numbers keep ebbing down ever so slightly in the last few days. We'd be expecting to see more testing now, wouldn't we? And if the tests are going down, testing amounts going down, why?
Well, thank you. Yes, and thanks. I forgot to address that part of the question, Jeremy. This is not a complete answer by any means, but one of the things we've discovered is that there's been a gap in the data, and one of the significant systems has not been reporting lab data. So there's actually an undercount in the data, but so I don't think it's falling as much as it has looked like it is, but it's not growing as fast as it needs to be, and that is something we're working very hard on. I mean, we've been talking for some days about kind of a general approach to how can we be better coordinated across all the different individual systems that are doing testing, and how can we knit that together in a more cohesive way that would allow us to fill in those capacity gaps in real time. And we've just been getting increasingly detailed about that plan and that strategy. So you can, as the governor has said, you can expect to hear more in the very near coming days about the specifics of just exactly how we're going to ramp up that testing capacity. We believe we can. We believe we've got the kind of the ideas and the agreements about how to build out that system, and we're just moving into the next phase of being able to really execute on that. So much more to come on that in the very near future.
Your next question comes from a line of Steve Karowski with the Associated Press. Your line is open.
Yeah, hi. This is Steve Karnowski at AP, and I'll have a follow-up on this. But sorry to hear. I just had to scroll back to something. It's with nursing homes and other long-term care facilities, are we actually doing testing of all the residents at these? I mean, if we are, what's involved and how it's done? Are there cases where we've had the lack of available testing or delays in testing has been blamed in some of these outbreaks we've seen at some of these facilities? And conversely, have we seen cases where getting tested has helped nursing homes or other congregate facilities avoid wider problems?
So, Chris, can you take that? Go ahead.
Oh, yeah. Did you want me to, or did you?
Yes, please. No, go
okay.
ahead. Thank you.
I'm sorry. This is the challenge of multiple locations. Sometimes we don't hear as well as we'd like. We are doing testing in some facilities. They have done extensive testing. They've had the capacity to test many, many residents. And in those facilities, we see lots of cases. In other facilities, they have had more challenges in having adequate testing capacity. And while we may not have identified as many cases, they are still implementing the important infection prevention guidance. But we're hoping that with the availability of of additional testing, that will help inform our response to these situations. So in some facilities, they have had the capacity to do additional testing. In others, less so. But the guidance that we have for many of the recommendations for infection prevention, they can be implemented, in the absence of those test results.
So this is Commissioner Malcolm. I just to maybe build on that point, because it does illustrate kind of where we've been and what we're moving toward. The testing strategy for the last weeks and months now has been really to relied on individual systems and what the capacity of each individual healthcare system has been to do the testing and to get access both to the supplies they need to do the sample collection, and then what a variety of arrangements that the individual care facilities have with laboratories to do the processing. But it's been kind of everybody on their own, so to speak, and what we're really trying to knit together now is a much more systematic approach so that it doesn't only rely on the variabilities of local capacity, but that we've got a statewide system that can really make sure that everybody that needs to be tested will be tested, including this more vigorous approach in congregate settings.
Your next question comes from the line of Tom Hauser with KSTP-TV. Your line is open.
Hello, Commissioner Malcolm. A quick follow-up on the testing situation. People are very frustrated because they keep hearing about the 5,000 tests a day. It's coming, and I know you said it sounds like there will be some announcement about that imminently here in the next day or two. But people are understandably frustrated even when they hear about a plan maybe in the next day or two about whether it's actually going to come to fruition. And I know the Senate has a hearing today where they're going to hear from the Mayo and U of M. What are they likely to hear today? What are the lawmakers likely to hear? And why should we be confident that when we hear there's a plan in the next day or two that this testing is actually going to start ramping up?
Tom, it's a fair question, and I get that people are frustrated because we've been hearing the goal is to grow testing, but we haven't seen it really materialize, and it's been one thing and then another thing about the reagents and the swabs and the personal protective equipment. But again, I just harken back to the prior comment about what we've seen is a real patchwork quilt of a mismatch between where there's need and where there's supply, and every system's kind of been on its own. And so what I think, I'm not sure what you'll hear in the legislature today, except that I think you'll hear from both the University and Mayo, and I don't know if other systems are commenting as well, about what they've been doing to add capacity and to build their own new methods that are less reliant on the same supplies that are hotly competed for globally. So some of it's been the development of new testing assays, new ways of different chemical combinations to be able to do the testing, and it's very important that those tests would be of high quality. So, you're hearing a lot about a lot of people who say, oh, yeah, we can do testing. We've got this drive-through test and this rapid response test, and it's really important to make sure that the tests are of high quality and accurate, because the last thing we want is a lot of testing that isn't of high quality that produces results that aren't very reliable. So I think probably you'll hear from the U and Mayo about both not only how they've added capacity, which they have been doing, which is what we're hoping to tap into to increase the reliability of the testing supply in Minnesota. But I hope they'll also talk about some of the interesting, forward-looking research that they're doing to improve the variety of tests that might be suited to different environments, and some of the new research questions that they're looking at.
And just a quick follow-up, because in order to begin easing some of the stay-at-home restrictions, if that's going to happen 13 days from now, it is still the case where we need to have significantly more testing than we do now. Is that accurate?
Yes, that's certainly the goal. But we also continue to say, there are places where testing is even more urgent and more helpful. And so, yes, while the goal is to get to a point where we can do the kinds of testing that will enable us to get a much better handle on, how many people might have been exposed to the illness that never knew it. I mean, that's a type of testing that will be valuable to sort of assessing the level of illness that we've had. But that's the cutting edge of that there's still hot debate about if we know as much as we need to know to make those kind of decisions. And that's what I'm delighted that both Mayo and the university are leaning into, trying to figure that out so that we can make the best use of those new kinds of tests. But I think that's just probably the best I can do for today is just to say it's the added capacity that's being built. Having the capacity is one thing. Being able to get the capacity to where it most needs to be is the other part of the challenge that we've been working on. But I think genuinely making good progress on. And you're fair to say we'd like to see that actually happening, actually coming to fruition, and not just being a plan. And I can tell you that no one's more anxious and focused on that than the governor. So we're working hard to fulfill that.
Your next question comes from the line of Tom Lydon with Fox 9. Your line is open.
Wondering what you can tell us about, you mentioned the contract tracing that you're doing in congregate living situations. What is that telling you about how it's being spread in congregate living situations, especially long-term care? I know one of the locations has had 6 deaths. A food service provider is suspected. Do you believe this is being transmitted resident to resident, or do you believe the vector is employee? And relatedly, do we have the virus being aerosolized in these facilities, perhaps through CPAP machines or other means?
Would you take that?
Yep. Well, a couple of things. One is that it's very likely in all of these situations that transmission is coming in from the community. And obviously, we made recommendations fairly early on about visitor restrictions and limiting, access to these facilities. But staff, as you said, and healthcare workers continue to need to be present to serve the residents. And one thing that we have learned over the several months that this outbreak has been ongoing is that we are now looking 48 hours before someone has onset of symptoms, looking at their potential for asymptomatic transmission. And so it's entirely possible that you can have a staff person or a healthcare worker who is working in good faith and may potentially have exposed residents. So yes, we do think that the fact that we were seeing transmission in the community, that is how it got introduced into these congregate care settings, whether it's long-term care, whether it's congregate living, a homeless shelter, a prison, any of those settings, it's being introduced in because of what's happening in the community. And then, just as we've seen in multiple different settings, we see rapid transmission because of the close contact between individuals in these settings. And that's why we're taking such rapid action to intervene, because unlike the transmission that you might have in a different setting, this is an opportunity where people are close together because they're living close together, because they're working close together, and so we need to make sure that we're intervening as quickly as possible. So yes, it's entirely possible that this is coming in to facilities through staff or healthcare workers, but I want to be very clear that we recognize that there is a period before someone has symptoms that they may be able to transmit, and so I think it's important that there are no assumptions made that people were working while blatantly ill. And then you asked about, airborne transmission, and I think that certainly there are certain procedures and certain things that can result in aerosolization of the virus, and so that is certainly possible. But I think that it's more likely because of direct contact between residents, caregivers, that type of thing. Did that answer your question?
It did. It got there, but of course, like all things, it raises two others. And my question is, if we believe we have asymptomatic spread that is coming from people who may be working at the facility, just as a possibility that that's an inroad, are we doing any testing at that point with a pulse oximeter? Because I know that that's been suggested as perhaps an early warning before people are actually, even with low symptomatic, we may see something in terms of blood oxygen saturation level. And relatedly, are we doing that for the residents? Because I know there is some belief that some residents in congregate care are getting to the hospital too late, that by the time they have shortness of breath, we've lost that battle. They're getting on ventilators and they're not making it off, that we aren't looking at the blood oxygen saturation level early enough and getting them to the hospital early enough. And just one final thing, you mentioned that you're looking at those congregate living facilities with previous infection problems. Have you noticed a correlation between the two? In other words, a place with lots of COVID infections that prior to this also had a poor infection record.
Okay, and then I'll take the first one, and I'll ask Michelle to take the second one. And yes, and I think you've used up your one question. But in terms of pulse oximetry, yes, we've talked about that. In fact, we were just discussing it in our morning meeting. That could be a useful tool. It's not something that's been implemented on a widespread basis at this point, but it is something that we've talked about because of the data that you suggested. I think, as the commissioner indicated, we'd like to see more widespread testing, and when that becomes available, that will also help inform decision making and making sure that cases are identified very quickly. And I'll let Michelle talk about correlations between past record and COVID.
Sure. Could you restate your question though for me?
Yeah, I think this is Jan. Michelle, I think it was. Have we seen a correlation between facilities that have large number of cases now and poor infection control records in the past?
So thank you for that, Commissioner. In some of them, we haven't done a full analysis of that. We are really analyzing what we have now for facilities. For some that have had bigger outbreaks, some recently have had surveys, and their infection control visits from the health regulation side were fine. And then they ended up having an outbreak not long after that. So it's still varied for what we're seeing, but that's part of our long-term planning, is to really get into that and to look at that correlation ongoing as part of our long-term planning.
Your next question comes from the line of John Croman with KARE. Your line is open.
Hello. Thank you again for giving us this update. A couple of things that have come up lately, kind of in the same vein. We heard Senator Jensen, or Dr. Jensen, on the Senate floor the other day saying that he thinks we already have all the capacity, hospital capacity we're going to need, so he doesn't understand the idea of pushing out, trying to push out the peak further than we already are. And in a related vein, you have Senator Benson yesterday sending out something and speaking about the fact that she thinks that the scenario 3.2 in the modeling has the same mortality factors as the scenario 4 in your modeling, which is most closely resembles what the governor's current orders have done. Any thoughts on that, Commissioner Malcolm?
Well, sure. I think, again, that we really appreciate all the work that's been done on the model, and the model will become increasingly useful, I think, as it has more Minnesota data in it, and we're able to adjust the assumptions. So, we're really grateful for all that work in the modeling, and we keep trying to stress that the model is of necessity, produces quite wide ranges of confidence in the estimates, and is really not intended to say, and therefore you should do X, but rather to look at the interaction between variables at a really high level, to say what's the relative contribution of more ICU beds and the relative contribution of less community interaction. So it's just I'm going to repeat every chance I get that it's intended to help inform what are the things we should be working on, rather than what is the right combination of actions. All that said, we're certainly mindful of the fact that we have, and glad about the fact that we appear to have made some real progress with slowing the rate of growth and using that time well to build up healthcare capacity. We are feeling like we've made good use of the time. What does that mean we should do next, I think, is the subject of a lot of discussion right now and a lot of different variables. The national guidance, including from the White House, is that you don't reopen, you don't loosen stay-at-home restrictions until you've had 14 days consecutively of decline, and not just slowing growth, but decline in the number of cases. So by that measure, which seems to have a fair amount of national concurrence, we are not ready to reopen. But we've also said that's not the only variable that the governor will be looking at, and he is working really hard to try to find ways of trying to figure out where it's more safe to reopen segments of activity that would seem to be less risky in terms of reopening, the opportunity for rapid and large scale transmission. So I'm kind of into the weeds there, but I think we certainly appreciate and understand people's questions and their frustration, as the governor says all the time. He's tired of it too, but we need to make a really careful assessment of what risk we might run of really seeing rapid increases if we don't have the right mitigation measures in place.
Thank you.
Your next question comes from the line of Theo Keith with Fox 9. Your line is open.
I just want to confirm, since it's been a few days since you've publicly said these numbers, of the 160 deaths, how many of them are associated with long-term care?
I believe Chris probably has that data. Do you, Chris?
I do, actually. Yep.
Okay.
It's 113 of the 160 deaths are associated with long-term care.
Okay, thank you. And then building off of that, some people will see that number and say, I don't know what the percentage is, but that's about 70%, I think. If the vast, vast majority of deaths are happening in long-term care, why not put tougher restrictions on people going in and out beyond what's already done, and loosen the restrictions on the rest of society? I could see that being a statement that's made when people hear that number.
Well, certainly there have been a number of restrictions that have already been made. I indicated in my comments that we were checking to make sure that all facilities had implemented visitor restrictions and limited group activities, but that recommendation was made a number of weeks ago, so that has been done. The challenge is that there are a number of individuals who absolutely must be going into these facilities because they provide care, because they're providing meals, any number of services, and so that becomes the challenge, that we cannot absolutely lock them down from interaction with the community simply because the caregivers and staff will need to be visiting the facility. But But it's a fair question, and I don't know if the commissioner wants to comment any about that.
Yeah, I would actually, just to point out that while yes, it is the case that a significant number, a majority now of cases deaths are associated with long-term care residents and the elderly in general. It's important to track the fuller picture of all the cases and all the hospitalizations. Long-term care residents actually make up a much smaller percentage of all cases hospitalized. So it's important also to know that there are a lot of people in the hospital, including in intensive care, in very serious condition that are not associated with long-term care. And we're really glad and proud of the fact that we have such excellent health care, that we've had some really, really ill people successfully recover thanks to the availability of the right health care resources. So we still think it's important, at these case numbers, a very, very small percentage of the public has been infected so far. And so we think the potential for pretty rapid spread still exists unless we're very careful and unless we continue to practice good preventive measures, good social distancing, good personal health behaviors. The potential for it to spread, quickly and widely and have some very negative consequences in the broader population is still there. And so that's as much as we are rightly focused on long-term care. This is still a broad population-wide risk.
Operator, we have time for one more question.
Your last question comes from the line of Walker Orenstein with MinnPost. Your line is open.
Hi. A little while ago, I had asked about some of the data breakdowns of testing by race. And you all had cautioned that it was still some pretty early data. I was wondering if there are any conclusions that you can now draw based on the testing that we've had and based on some of the data on percent of death, things like that. So looking at the race and ethnicity data, can we draw any conclusions yet, and what would they be?
Chris, you want to take that?
Yep. And let me just say that one of the challenges is that we receive, we have race ethnicity data for a number of variables, but when we receive data from the laboratories on negative results, they do not provide that level of detail. So while we can say we tested, 1,000 people today and 100 of them were positive, we can't tell you the racial breakdown of the individuals who may have had a negative test. So just to make sure that I make that clear. If we look at racial breakdowns, what we're seeing that many of our populations initially were underrepresented in our testing and remain underrepresented in our data. But we think that what we're seeing based on our race data is based on both the availability of testing based on occupation and living situation. But if you look at the percent of our cases, 13% of our cases have occurred in blacks. 5% of the deaths have occurred in blacks. If 61% of our cases are white, 71% of our deaths are white. So we're seeing a higher proportion of deaths actually in our white and American Indian Alaska Native population than we're seeing in other populations. But it's important to note that our American Indian and Alaska Native population, or the individuals who have identified that as their race, is a very small proportion of our cases. So we have to be careful in how we interpret that. So that's an overview on deaths. But certainly, we're seeing an incidence rate in our populations of color that are higher in our black population, that's higher than what we're seeing in our white population.
And just to kind of conclude by making a point we've made previously, is with this needs to be a continued focus and continued outreach into the communities that we know are more vulnerable for serious disease because of the existing health disparities and health inequities in all the range of illnesses that tend to make a person more vulnerable to more severe disease. So this remains a really important thing for us to be not only watching the data, but proactively working with those communities who we already know are suffering health disparities. So thank you very much. And Mike, I think we're going to wrap it there.
Yes, thank you, Commissioner, and thank you to everybody for joining us for today's call. If you had a question you weren't able to ask, please feel free to reach out to MDH Communications this afternoon. The number is 651-201-4989. Thank you very much.
Find more local news stories at ccxmedia.org and follow us on social media.